Thank you very much, sir. The next session will be chaired by Dr. Pushpa Veerasinghe and Dr. Dushanti Veerasekara.
Good morning. Now this session is a session on questions and answering, and the resource person will be Dr. Udari Apsara Liyanage. Dr. Udari Liyanage is a senior lecturer in the Department of Anatomy, Faculty of Medicine, University of Colombo, and she is a consultant radiologist practicing with a special interest in breast imaging at the University Breast Health Center. And she is a member of the Board of Study in Radiology, PGIM, University of Colombo. She is holding many important positions in national professional bodies, and she has received many research awards. And her current research interests are breast imaging and forensic age estimation. She has many publications to her credit also. And the technical part of this session will be explained by Mr. Kamal. You are given 20 seconds to answer, and the person who gives the correct answer will be displayed in the screen. Mr. Kamal will explain how to answer.
Good morning, doctors. This is a web-based question and answer session. First of all, you need internet connection to your smartphones. Either you can use your own data. If not, we have created a Wi-Fi network. You can go to the Wi-Fi connections and search. Then it will come. There will be CGPSL network that will come. The password for the network is CGPSL AAS, all in capitals, 2022.
Yeah.
SSID is CGPSL, search for that, and then the password is CGPSL AAS 2022, CGPSL AAS in capitals. That is, if you want to use this Wi-Fi connection. If not, you can use your own data in the phone. I hope the internet connection is okay now. Then go to internet. Either you can scan this or type slido.com. You have to, after getting into Slido, you have to enter this Q&A code. Hashtag 4105731.
Can we start the session now?
We can see only a few doctors have joined. Maybe we must give about, if you can, about 30 seconds.
How many have joined?
41 doctors have connected so far.
Over 50 will start. Over 50 will start. Shall we start now?
Yeah, okay. Shall we?
Yeah, yes.
All right, okay. So, is it good morning? Still good morning, no? Right, okay. So, good morning, everybody. A big thank you to the College of General Practitioners for inviting me again to talk radiology with you. So, this time, this session, of course, you'll be talking, right? I'll be presenting the questions, right? Just you'll be talking through your answers, right? So I have actually about 16 questions. Each question there is a stem and obviously a radiological image, an X-ray most of the time, and responses, 4 responses, A, B, C, D. You need to select the best out of the 4 responses looking at the radiograph or the picture, okay? So I'll tell you when to start answering, okay? So first I will read the question and then I'll tell you to start. You'll be given 20 seconds, I suppose, to answer. After that, you will close the answering session, and a person who gives the correct answer first, the name also will come up, you said, right? Okay. So let's go. Okay. So this is the first question to you. A 45-year-old woman with fever and cough for 10 days. This is her chest radiograph, chest X-ray. What is the chest X-ray finding? A, left low lobe consolidation. B, left pleural effusion. C, left diaphragmatic hernia. D, right low lobe emphysema. Okay, start. Is it okay? Finish?
Yes.
Okay, right. Okay, you can tell me when the time
20
goes.
seconds. 20 seconds.
20 seconds.
20
Okay,
seconds.
right. So I think 73% have got the correct answer, which is left low lobe consolidation. So that's really good. Can you see my slides? Okay. So I just want to share this slide with you. Okay.
Dr. P.S. De Silva
Dr. P.S. De Silva
has given the quickest answer.
Yeah, okay, right. In that is 0.6 seconds, I suppose. Okay, let's quickly go back. Yeah. Okay. So the answer, you know, you can see. Can I? Sorry. Go back. Go back. How do I get the pointer here? All right. Okay. So basically, you can see the opacification here in the lower zone, and the left hemidiaphragm is not seen there, and but the left heart border is seen, so it is not lingular consolidation. It is a left lower lobe consolidation. On the lateral X-ray, we do not do lateral X-rays. This is for just interest sake. You can see as you go down in the lateral X-ray, the vertebral bodies usually become darker. They become more black. Here, you do not see that. So it is a lower lobe pathology, and also you see only one hemidiaphragm. You can see the splenic flexure going there without the diaphragm outline, so the diaphragm is obliterated. So this is silhouette sign telling that it is a left lower lobe consolidation. Okay, so let's go to the second question. That's really good. Huh? Okay, so 6-year-old child with fever and productive cough. This is a chest X-ray. What is the most salient feature on this chest X-ray? The most salient feature I'm asking: A, left effusion. B, left lower lobe consolidation. C, left lingular consolidation. D, left lung abscess. Easy to go. Okay, start.
Right.
Okay, we got the answers. 57%. I thought everybody will get it correct. Okay, it's the correct answer is a left lung abscess. 57% have got it correct, and lingular consolidation I also about 25% have got. We'll discuss it. So
CA.
CA. Okay.
CA.
Whoever that
Can
is.
you
Dr.
raise your hand? CA.
Oh, that's great. Okay, right. Okay, shall we go to the go back? Yeah. Okay. Now, people who said left lingular consolidation, you're correct. There is a left lingular consolidation. Unlike the previous X-ray, here the left diaphragm is nicely seen, so lower lobe is cleared. But there's a consolidation here, and the left heart body is gone. Yes, there is a lingular consolidation, but we asked for the most salient feature. You are expected to find this small air fluid level, so that's an abscess. Okay, so the most salient feature is left lung abscess. I have another slide for you, just to show you, comparing with the previous one. You see the vertebral bodies become dark as we go down. Last picture there, last X-ray, it was not like that. And you do see both hemidiaphragms, both hemidiaphragms are there. So the lower lobe is cleared. It's a lingular pathology, overlapped on the heart. I think I've lost the pointer, that's okay. So basically, you see the air fluid level superimposed on the heart there. Right, so let's go to the next question. This is the CT, showing again, I cannot use the cursor, I need a pointer. It's okay. Okay, that's all right. So you can see the air fluid level. You can see the air fluid level in the CT also, telling that the abscess is there. Okay, right. So let's go to the next question. This is a young patient with acute shortness of breath and chest pain, mild chest pain, right, and mild shortness of breath. This is the X-ray, a young adult. What is your conclusion? Emphysema, pneumomediastinum, pneumothorax, normal. I do have normal X-rays, okay? Okay, you can start. Oh, so pneumomediastinum is the correct answer. We've got the majority going for pneumothorax.
Dr.
Ken Adams. Do we have the
Dr.
honor
Ken
of knowing
Adams.
who Dr. Ken Adams is?
Can you raise your hand, Dr. Ken Adams?
Okay, right, okay. So, so this is the explanation slide. Just can I go back? It's changing automatically. Okay. So if you look here, I'm sorry for not having the pointer. You look if you follow the white line which is coming down from the on the left side, that's thick line which is separated by the heart down there. That is the mediastinal pleura, which is kind of pushed off away from the mediastinum, saying that little stripe there is air. Okay, so it is pneumomediastinum. There is no pneumothorax. You do not see a lung edge or peripheral hypertranslucent areas. Just to prove myself, this is the normal CT thorax. That is the patient's CT. You can see between the lung and the mediastinum that black colored, let's not change the slides, okay? Right, okay, the black colored area is air collector. So you can, if you look at that, that's great. Can I have pointer? Okay, right. So you can see between the lung and the mediastinum, you see air coming up. Air is black. Oh, hi. Yeah, that's great. Thank you so much. Thank you. Great. Okay. That's a mediastinum, that's a lung. You see air collected between the mediastinum and the lung, which is not seen here in this picture, okay? So this is pneumomediastinum. Okay, right. So let's move to the next one. Question number 4. This chest X-ray. I'm sure all of you get X-rays which are medical checkups, which are taken for the purpose of medical checkups. So this is a man awaiting foreign employment. This is his X-ray. What is your conclusion? Are you going to report it as bilateral low lobe bronchiectasis, right mid-zone consolidation, pulmonary hypertension, or normal? Okay, you can start answering. Okay, right. So 50% have got it correct. This is a normal X-ray. Where did we go wrong? Bilateral low lobe bronchiectasis. Not really. Now these, yeah, Madhushan.
Madhusha.
That was very fast. Okay, 0.03. Okay. Basically, these are lung markings. On digital X-rays, you do see a lot of lung markings, which are mostly vessels. We are used to seeing, the analog X-rays, but when digital X-rays are done, you do see a lot of markings. This is not bronchiectasis. These are just normal lung markings. Okay, right. So that wasn't so bad. Okay, so let's go to the next one. Just before going to the next one, this is just a normal chest X-ray I put for you all to see. If you can see the diaphragms and the cardiac borders very clearly, and the lung markings nicely without any ring shadows or tramline shadows or any patchy infiltrates, then there's higher chance of the chest X-ray being normal. Having said that, even senior radiologists sometimes have to scratch your head and think before calling something normal. So I suppose to call a chest X-ray normal is a challenge, right? But you're at an advantage because you have the history most of the time, and radiologists don't. Okay, right? Okay, so that's not so bad. Let's move to the next one. Fifth question: a 55-year-old previously well woman comes to you complaining of fever, cough, and shortness of breath for a few days duration. What is the most probable diagnosis looking at the clinical picture and the chest X-ray? Pulmonary edema, lung fibrosis, COVID-19 pneumonia, bronchiectasis. Okay, we can start answering now. Okay, right. So can we have the correct answer? Yeah, right. Okay. So this is, I think all of you must be quite familiar with this case scenario, although you may not get a lot of chest X-rays, they go to the hospitals naturally. Dr. Haroon Tawfiq has got the correct answer very fast. So it's a patient with COVID-19 pneumonia. Let's go back to the question. Yeah, okay. So what you see here is, you see bilateral abnormalities. Obviously, it is not normal. And all these are patchy abnormalities. And some mostly more in the lower zones than in upper areas, and more peripheral than central. And they are all patchy, almost ground glass kind of patchy shadows with few consolidations here. So this is the typical pattern on COVID-19. Obviously, this is like an atypical pneumonia, so you have to have the history and PCR also for diagnosis. It is unfair for me to ask you to diagnose this without the PCR, but then I can't have the PCR on this, then it will be very obvious. That is why I didn't put it. So having said that, chest X-ray interpretation, it's not fair to ask without proper history. We always report the X-ray with the history. Okay, so chest X-rays have to be interpreted in the context of the clinical history. So let's go to the, that is the CT scan. I've shown you several CTs now. This is lung window, CT thorax, showing this is a normal lung. You have seen it before, see the mediastinum and all that. Here you see the ground glass attenuation here, there, mostly peripheral. a little bit of consolidation here. Consolidation is when there is whiteness without the background being seen. Ground glass it is haziness through which you can see the background vessels. Okay, so this is bilateral, mostly bilateral peripheral ground glass opacities. Okay, in the context COVID-19, right? It has to be compared with PCR. Next question: 60-year-old man with a dry cough. COVID-19 PCR negative this time. Okay. But there is a past history of COVID-19 pneumonia. 6 weeks back, he was admitted in the hospital for a few days. And this is the chest X-ray. He has brought that also to you, the first one, the first X-ray. That is what he had 6 weeks back. Then at the peak of his pneumonia, then he was discharged. He was okay. He went home. He was okay for 4 weeks. Now this time coming with dry cough. This is the current chest X-ray. So looking at the current chest X-ray, what is the most probable diagnosis? Reinfection, persistent inflammation, lung fibrosis, bronchiectasis. Okay, let's go. Start. I think it's good if we can have the X-ray for a longer time without changing to the, without changing to the answer slide. Let's have the X-ray as long as possible. Okay, last minute we can show the results. Okay. Lung fibrosis. Okay, so more than 50% have got the correct answer. Yes, this is lung fibrosis. As all of you are aware, this is a problem, a complication after COVID-19 pneumonia. And Dr. Madhushan, I think coming up for the second time, no? This name? Yeah. Okay, that's great. Okay, congratulations, Madhushan. Okay, so if you compare with the X-ray on this side, which was his acute phase chest X-ray, which has a lot of basal opacities, basically a lot of it has cleared up, but not quite. There are some residual changes here. The most hardly hit ones have just got some residual changes here. It's difficult to make a call of lung fibrosis looking at this chest X-ray. That is why I ask why it is a most probable diagnosis. You have to combine with the history. But to confirm, you will have to do a HRCT. So this is HRCT. This is the typical fibrosis appearance on chest X-ray. You see septal thickening with central lucent areas, almost like honeycombing. So there is some bronchiectasis also. These bronchi, as you can see, this is a reconstructed coronal image. Bronchi are dilated, obviously, but we do not call this bronchiectasis. This is traction bronchiectasis, or secondary dilatation of bronchi as a result of fibrosis. Okay, so the answer is lung fibrosis. So let's go to the next question. Question is, an 8-year-old boy who has come to you the day before with cough and you have given some treatment, now comes today afternoon and the mother says mild shortness of breath since today morning. This is a chest X-ray. What is the explanation for this shortness of breath based on the chest X-ray? A, foreign body inhalation. B, right upper lobe pneumonia. C, right upper lobe partial collapse. D, right side pneumothorax. Okay, we can start. We'll keep the X-ray until the last moment, okay? Okay, time up. 47. Almost there, almost 50% have got the correct answer. Right upper lobe partial collapse. That is the correct answer. Yeah. Hasara Kulatunga. Okay, congratulations, Hasara Kulatunga. That's great. Okay, let's go back. Okay. So as you can see, there is opacification here, which is which with a very fine, very clear demarcation here. This is a collapse actually. So this opacification, as you say, can be a consolidation also. We don't see bronchograms, but can be a consolidation. But why I'm saying it is a collapse is because there is evidence of loss of volume, as seen by upward deviation of the horizontal fissure. This is the horizontal fissure. It should have been like this. So it has gone up because there's loss of volume in the upper lobe. Okay, so it's a upper lobe segmental or a partial collapse. When that happens, because of loss of volume, they are in the upper lobe. What sits anatomically just under the right upper lobe is the middle lobe. So the middle lobe expands and the fissure is drawn up. I have another X-ray to show you here. So this shows, this is another patient with total complete collapse of the right upper lobe. This is partial collapse. Okay, in both cases you can see that the fissure has gone up, which is why we are calling it a collapse. Okay, right. So let's move to the next question. Chest X-ray of a 1-year-old child with cough and fever. Looking at the X-ray, what is the diagnosis? Viral pneumonia, bronchiolitis, round pneumonia, normal chest X-ray. This is the diagnosis based on the chest X-ray. I'm asking about the chest X-ray, okay? The child has fever, but what about the X-ray? We can keep the X-ray and you can start answering. Okay, the correct answer is round pneumonia. I suppose it's unfair for the people who are sitting at the very corner, you may not have seen. There is a, okay, yeah, there is a opacity here, okay, fairly circumscribed opacity here. We can call it, actually, it looks like a mass. This is a round pneumonia. It is the patch of consolidation which is round in shape. Round pneumonias, as you know, they occur in children almost exclusively. There are case reports in round pneumonias in adults, which is not very common in adults. So almost exclusively seen in pediatric imaging, often caused by Streptococcus pneumoniae. And it is the pediatric anatomy that limits infection to a focal area, round area. So it's nothing dramatic about that. It is just a consolidation which has got limited to an area. There is no cavitation, no abscess formation. So it looks like a rounded area here on the CT. So the answer is a round pneumonia. Okay, right. Let's go to the next question. This is now we are moving from chest X-rays. This is a lumbosacral spine X-ray. So in this X-ray, this is an X-ray of a 70-year-old man in your practice. Looking at the X-ray, I have not given much history. What do you think? Is it normal? Has he got osteoporosis, sclerotic metastasis, or degenerative changes alone? The best of the four. Okay, we can start answering now. Okay, the correct answer is sclerotic mets. Yes, you're correct. He has degenerative changes. I do agree. That is true. So, can we have the winner? Last time also we forgot to announce the winner. Madhusha. Madhusha or Madhusha.
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 She is there.
Madhusha is a star, no? You can't see properly also. Okay, right. Okay, congratulations, Madhusha. Yeah, we go back to the slide. Okay, so basically, there are degenerative changes. You do expect to see some degenerative changes at 70 years of age, but we cannot. We have to pick the best answer, which for the benefit of the patient. This is sclerotic metastasis. You can, when you look at this X-ray, especially the lateral X-ray, you can see the vertebral bodies are of different. They look very heterogeneous. So when you see something like this in a 70-year-old man, you have to be very careful. You can't just pass it off as normal. You need to do at least your PSA at least to check what's going on. I know it's not very clear, but if suppose if you had a X-ray like this, here you can see sclerotic mets very clearly. Nobody's going to miss this there. But it doesn't come like that always. Sometimes it is just very heterogeneous and ugly looking pelvis and spine. So the previous X-ray which we saw, this is the MRI scan, T1 weighted MRI scan of the spine, lumbar spine of the same patient. You can see even in the MRI, in the T1 weighted MRI, the vertebra are usually white because of the fat. We have fat in the vertebral bodies, so usually they are white. So all these black areas, this one is fully black, all that is metastasis. Okay, that's fully black. See, this white vertebra is this one. It's totally kind of replaced with metastasis. Okay, so this is metastatic disease. It's a patient had CA prostate past history. I did not mention that because then I will lead you to the answer. Okay, so with clinical history, I'm sure it's easier. Shall we go to the next one? Again, X-ray lumbar spine, 45-year-old man with low back pain for several months. You normally don't jump into taking spinal X-rays, but then it goes on for some time and a lot of complaints. You go and you did this X-ray and this is what you found. What is the diagnosis? Infective discitis, degenerative disc prolapse, spinal metastasis, spondylolisthesis. Okay, we can start answering. Okay, we are supposed to go fast. Degenerative disc prolapse has been is the answer given by most, but the correct answer is infective discitis. You cannot afford to miss Dr. Haroon. Congratulations. Okay, let's go to the answer slide. Okay, right. So basically, here normal vertebra, normal disc phase, vertebra displaced, and this part is quite okay, but here the disc, as you have detected, yes, the disc height is reduced, but you need to look at the in degenerative disc disease, you do not see this kind of irregularity and sclerosis on adjacent vertebral end plates. This is end plate destruction. This is infective discitis. This can be tuberculosis, TB. So the disc disease with infection of the adjacent vertebral end plates. Okay, so let's move on. There, this normal disc, normal vertebra. No, this is an abnormal disc. You can hardly see the disc, and adjacent vertebral end plates are also damaged. Okay, so infective discitis, important not to miss. So let's move on. A 25-year-old man with knee pain for several months, young adult with knee pain, X-ray of the knee. What is the diagnosis? Osteoarthritis, medial meniscal tear, bone tumor, osteochondral defect. Okay, let's start. Okay, so the correct answer is osteochondral defect. We'll keep the slide just for a few seconds. Okay, so Dilakshana Piris, congratulations. Let's go back. The correct answer is osteochondral defect. Here you can see a tiny defect here. Can you see this little piece missing from the bone, right? So bone piece missing here, and with that we cannot see the chondral defect, but this is associated with the chondral defect. As you can see here, when you see that, MRI is indicated, and on the MRI you can see a piece of bone plus the articular cartilage both gone. So this is osteochondral defect. This is an osteochondral defect. Sometimes this can detach and form a foreign body inside the joint with foreign body like symptoms also. I just want to make one comment before going to the next question. Medial meniscal tears can be associated with this, but we will not diagnose a medial meniscal tear on an X-ray. We do not see cartilage on X-rays until, so that answer is not acceptable. Okay, he may have it, but we cannot diagnose that on X-ray. Okay? Right. So we are short of time. Yeah, we have like so. Okay, I'll just quickly go through. A 25-year-old man with midfoot pain and past history of ankle sprain. You can actually start answering. Shall we start answering while I read? Fracture second metatarsal, subluxation of fifth metacarpophalangeal joint, calcaneal fracture, navicular osteonecrosis. Okay, so the answer is a lot of people have got the correct answer. That is navicular bone osteonecrosis. So it's quite straightforward, I suppose. Yeah. So this is the navicular bone, which is white and sclerosed. Okay, so that's good. Can I skip one or two? Is that all right with you? Right, okay. Right. So the X-ray is not very good here, so we'll have to skip it. When it's projected on the screen, it has become really dark. I'm sorry about that. Yeah. So we'll go to the one before the last. This is a 20-year-old, I'm not asking you to interpret the X-ray. 28-year-old woman with BRCA BRCA gene mutation. She does not want prophylactic mastectomy. Okay, so what is the preferred breast screening option for her? So she has to undergo breast screening. What is the option for her? What will you tell her? Mammography once in every 2 years, starting at 40 years. Annual breast ultrasound, annual mammography, annual breast MRI. She's 28 years old now. Okay, the answer is okay. Answer is annual breast MRI. Very few people have got that as the correct answer. Madhusha, congratulations again. This is high risk group. So she belongs to the lower category, high risk group. There's a very high chance of getting lifetime risk of breast cancer. So normal screening is not good enough. Ultrasound is not good enough. We need to do MRI starting from the age of 25 years. There are different guidelines by different societies. We do not have guidelines. That is why I put it here. You have to ask for guidelines for high-risk group at least, because we don't have national breast screening in this country. So if somebody is BRCA positive in your community, you need to know what to do for her. We have to do MRI starting from 25 years annually, and we can add mammography 30, 35 or 40 years depending on the guidelines. So we don't have guidelines for that. So that is the answer. So I'll finish off. I will not put this to the audience. I don't want to waste this slide. Basically, a GP requests a X-ray for a child with fever and cough. I put this because I put so many pediatric X-rays. Before you ask for X-rays for pediatric population, you need to consider the risk and the benefit and ask only if you really need it, because the risk of cancer, lifetime risk of a child developing cancer due to this particular chest X-ray is 1 in a million. Okay, so there is a risk of cancer which will be caused by you. And so you have to be very careful. So thank you so much. Sorry for taking a few minutes more. I think we spent some time giving the instructions.
Thank you,
Okay,
Udari,
thank
for that very interesting session. And I invite you to accept the token of appreciation from Dr. Veerasekara. Our next resource person is Dr. Chamara Ratnayaka. I invite him to come to the stage.
Dr. Chamara Ratnayaka. He is a consultant cardiologist and he is resident cardiologist for the RCD group of hospitals in Colombo. And his special interest in interventional cardiology, especially for acute coronary syndromes. I haven't got any more data about him. This is all I have got. So we invite you to.
Thank you very much. I actually prefer not to have long introductions, so that's perfectly all right. And thank you to the College of General Practitioners for inviting me once again to have a short talk. I do apologize that my talk is probably not going to be as interesting as the previous one. So I think my task will be to try not to make you fall asleep, and I'll try my best not to do that. So I was asked to talk about anything that I thought would be good, and I said hypertension is something that we probably should talk about, and I'll tell you why in the coming slides. So, they asked me for the name of the topic. I said, let's just do hypertension, and then Dr. Sunet said, that sounds boring. So this is, so to be quite frank with you, this the topic that you see in front of you is not my own. So Sunet is the one who suggested this. So detect, protect, correct. Hypertension, a GP-centric guide. So yeah, so basically it's a important topic for general practitioners, I feel, to know how to detect hypertension, and how to deal with it. I have no conflicts of interest, just disclose that. So I usually I start my slides off with talks rather with a slide which is a quotation. So this I thought was interesting given the current context in this country as well. When we hate our enemies, we are giving them power over us, power over our sleep, our appetites, our blood pressure, our health, and our happiness. So even our blood pressure is determined by our mental state. And I was quite tempted to cut off enemies and put politicians there, given the current context of our country, but I thought I'd probably avoid controversy. But yes, our blood pressure is dependent on many things, but definitely our mental state is something that's very, very important, and our patient's mental state is also important to keep in mind when we are treating them. So why is hypertension important? This is a slide which is from the WHO, and you can see, so as we talk about leading causes of death, any cause, and it depends even from the economic state of different countries. You can see high income, middle income, low income, the colors you can see. High blood pressure comes right up there as the number one cause. In most countries, you can see tobacco use probably is a little bit higher as far as the cause of death is concerned in high-income countries, but in low and middle-income countries, I don't know what we call ourselves these days, bankrupt maybe, but we used to be called middle-income. So you can see that hypertension is the leading cause of death in our part of the world, if I were to say so. So it's very, very important to understand that this is something that we need to tackle and something that we need to control as much as we can. And from a general practitioner's point of view, so this is a study done in Canada a couple of years ago. You can see that as far as reasons for visits, so RFVs means reasons for visits to clinics, to general practitioners' clinics. Hypertension is number 2. I think you probably would agree, those of you who do have practices going on, that majority of your patients would be having hypertension, and that's something that you need to deal with, secondary to respiratory tract infections. And I think that this can be extrapolated to Sri Lanka as well. So it's something that you will, as general practitioners, come to deal with very, very often in your practice. So it's important to know how to deal with it as well. So again, this is a slide from the WHO again, and this is quite a damning slide actually, which I found quite surprising, but it's something that we should know. So as far as prevalence is concerned, burden of the disease of hypertension in Sri Lanka, we have a population of about 20 million, 26%, so about quarter of the population have hypertension. There's an old slide, I guess, from 2014, but I think it's pretty much the same. So it's about 3.6 million. However, the slide on the right, or rather the pictures on the right, the one in green, is the more damning of the data that we have. So of these 3.6 million people who have been diagnosed or who are known to have hypertension, 3.2 million of them do not have it under control. So isn't that something very surprising? I found it very surprising myself, to be honest, to read this. So only 0.4 million or 11% of people who have hypertension have it under control. So, and of them, again, 1.4 million you don't even only know that they have hypertension. So that's quite a high number who don't know they have hypertension already. And 1 million is undertreated, and only 0.4 million have it under control. So only 11 to 10% of people have their pressure under control. So that's a big problem, I feel. And no wonder hypertension is a leading cause of death, because if majority of the people don't have it under control, obviously that will lead to complications, as we all know. And it's something that we need to address. And I think the point where we start should be from the general practitioners, because general practitioners are the ones who deal with most people with hypertension quite commonly. And I think we need to address this, and we need to get the general practitioners more aware of what's going on, and to diagnose hypertension and know how to treat it optimally as well. So most of my slides, which will be coming as well, will be based on this paper published in 2020 by the International Society of Hypertension. So this society, basically a culmination of many organizations, including the Europeans, Americans, because there are always discrepancies between, across the Atlantic, but there was a consensus almost which has come to by 2020 about how to treat. So again, one of the things that they try to figure out is why is there such a big disparity in hypertension burden. So for example, why is there such a disparity between control of hypertension between low and middle income countries versus the high income countries? So one of the reasons, or a couple of the reasons rather, is that awareness and treatment and control rates were poor in the low and middle income countries compared to the high income countries. And one of the reasons probably is because the lack of guidelines, and that's something that I think we in Sri Lanka as well we lack. We don't have proper guidelines as far as treatment of chronic diseases, and including hypertension is concerned. I believe the last guideline in hypertension was more than 10 years old. So things have changed since then. There are more treatment available, new guidelines in all over the world. So majority of the low-income countries or low-middle-income countries don't have guidelines of their own. And then what happens is we rely on international guidelines. We rely on European guidelines. We rely on American guidelines, which may not be suitable for our population, because every country, the population changes. The way that we react to medications changes. So I think it's important that Sri Lanka develops guidelines of our own, and it's something that we put forward to the medical associations, to the College of Cardiology as well, where we are trying to see if we can come up with some new guidelines as far as hypertension is concerned as well, which will hopefully lead to better control, and we can improve on that statistic that I showed before, that only 0.4 million or 11% of our people have their pressure under control. So ladies and gentlemen, the next few minutes I'll be going through basically the ways to detect and correct hypertension. So let me just show a small roadmap as to what we will do. So how to diagnose and what's the definition of hypertension. I think that's important to know from every aspect, from a general practitioner to consultants. So I think we should know how to diagnose a patient, whether they have hypertension or not. Let's talk about a few causes. So I think most of you know that about 90% of people have what we call essential hypertension, where there is no cause, it's genetic, but a few secondary cause of hypertension are there. Let's have a quick chat about that. Patient evaluation is important. I'll just have a quick talk about that. Management principles, that will probably be the climax of the talk, where we'll talk about non-pharmacological and pharmacological management of hypertension. And lastly, but I think very importantly, how to follow up a patient who has been diagnosed with hypertension. So big journeys start with small steps. So let's start our journey as well. So how do we diagnose a patient with hypertension? So a patient comes to your clinic and they come with many symptoms, many aches and pains sometimes, but I think standard thing that we do in almost all patients who do come to our clinic is check their blood pressure. So a systolic blood pressure in the office more than 140 or a diastolic blood pressure more than 90 is reasonably enough to diagnose hypertension, but please remember that a single measurement is not enough. A single office measurement is not enough to come to a conclusive diagnosis that your patient is having hypertension. So you need multiple readings. So usually 2 to 3 office visits at 1 to 4 weeks apart are required to confirm the diagnosis of hypertension, unless your patient is having a single reading of a high blood pressure of more than 180 systolic or 110 diastolic, and there is evidence of cardiovascular disease. So one reading, if it's very high like that and the patient has cardiovascular disease, it's sufficient to come to a diagnosis of hypertension. But in other circumstances, you need multiple readings. So 2 to 3 visits are important to come to a significant diagnosis. Sorry about that. However, rather than office visits or clinic visits, again, the recommendations and the guidelines also suggest, rather than just single office visits, the ideal thing to do would be to do so-called ambulatory blood pressure monitoring. So that is a 24-hour ambulatory blood pressure monitoring, where you hook up the blood pressure monitor to them and they go home and they come up with these statistics, or the average blood pressure over a 24-hour period, daytime average and the nighttime average. So in a patient who has had an ambulatory blood pressure done, a 24-hour ambulatory blood pressure done, if the 24-hour average is more than 130 systolic or 80 diastolic, that is sufficient for a diagnosis of hypertension. And again, you can see the daytime and nighttime averages. So you would have heard again that your blood pressure should normally, there's a diurnal variation where the blood pressure should dip at night. So if the daytime average is above 135 or 85 diastolic, or if the nighttime average is above 120/70, again, that is a reasonable evidence to diagnose hypertension, and that's the ideal circumstance. Home blood pressure monitoring, where you ask the patient to, I think it's something that's done commonly these days. A lot of people do have these blood pressure monitors at home, where you ask them to monitor their blood pressure at home and come up. I ask them to, that's what I do in my practice as well. I ask them to write down in their notebook and show to me once they come to the clinic. Again, home blood pressure, if they check it, it's more than 135 systolic or 85 diastolic, reasonably sufficient evidence to diagnose hypertension. So these out-of-office blood pressure measurements, again, are the weapon of choice, I guess, in diagnosing hypertension. And what they say is much more reproducible than office blood pressure measurements. And it does closely associate with so-called hypertension-induced organ damage. So I will talk about what this hypertension-induced organ damage is in the next few slides. But again, it helps to also differentiate between the so-called white coat hypertension and masked hypertension. I'm pretty certain that you would have heard about them as well. However, I will talk about how to define them in the next few slides as well. But it's important to know and to come to a conclusive diagnosis. So again, out-of-office blood pressure measurements are probably the ideal way of diagnosing. However, we need to keep in mind that this is not always a practical thing to do, especially in our circumstances where there is a cost involved and some people may not be able to afford it. And in the government service, again, the numbers are too much for us to obviously recommend it to a lot of people. But we need to know what's ideal as well. So this is pretty much the ideal thing to do. So a couple of other things that I just mentioned before as well. So we get patients who get so-called isolated systolic hypertension, where the systolic pressure is high, above 140. However, the diastolic is less than 90, seen in young and old. So the two extremes of life, and especially in the elderly people. And the reason behind it is what we call arteriosclerosis, where the arteries get stiff. And when there are stiff arteries, the systolic blood pressure goes up a bit. White coat hypertension, again, where we've heard about this before, where the blood pressure is high in the office, usually because of stress, etc. But the interesting thing here is that patients who we normally brush it off to people who have white coat hypertension, we tell them nothing to worry, your pressure is okay at home, it's just high when you come to the office, nothing to worry about. But the interesting thing is these patients are not necessarily risk-free. There is an intermediate cardiovascular risk in these patients, so they are not necessarily out of danger. Those who have white coat hypertension, when their blood pressures are high in the office, there is a slightly higher risk of getting heart problems, cardiac involvement, compared to those who don't have hypertension. So that's something that we need to keep in mind. Lifestyle interventions probably important there as well. Masked hypertension is pretty much the opposite, where the blood pressure is normal at your clinic or office, but when they check the blood pressure at home, it's high. I wonder why. Home circumstances, probably. More men than women? Don't quote me on that. Yeah, so those are your definitions. So again, the next thing we talk about slowly is the causes of hypertension. As I said before, so overwhelming majority of people, so more than 90% of people who have hypertension, as we call it, are having essential hypertension, no real cause, genetic probably. However, there are a few patients who do have secondary causes, so it's something that we need to think about, especially young people. And this definition of young hypertension is a very fluid state. A few years ago, we used to say anybody who has hypertension less than the age of 40 would be categorized as a young hypertension patient, but I think we probably should change that definition now as well. We get so many people who have pressure at a lower age, in their 20s and 30s as well. But generally, if you get a patient who has hypertension, it's always important to rule out some secondary causes, because if we do find that they do have any of these secondary causes, we can treat the cause, and essentially that will treat the hypertension as well. Some common ones, I'm not going to go through all of them, but a few to remember and think of the suggestive features. So renal artery stenosis, something which can be seen, and the way to detect it is if you hear a renal bruit on auscultation, and sometimes you get, and you can suspect it as well, if their creatinine level goes up after commencing them on an ACE inhibitor or an ARB. A coarctation of the aorta, again something that we can see, and we get a few in cardiology practice as well. Again, one way of detecting it is if you have a different blood pressure between the arm and the leg, more than 20 millimeters mercury, or there are the so-called radioradial or radiofemoral delays when you check their pulses. Endocrine causes, important, so thyrotoxicosis, hyperaldosteronism, pheochromocytoma, Cushing, so a few endocrine causes that we can think of with their signs you can see there. I'm not going to waste time on talking about them too much. One thing that I do see quite often in practice as well is obstructive sleep apnea. I think it's important to think about as a cause of patients who don't have very well controlled hypertension. Think about it as well. Then the next few slides will be about patient evaluation. I think it's important to know any patient, you need to know how to deal with them. So a medical history is important, whatever said and done. You need to know the physical examination point of it and investigation. So the point of doing investigations in patients with hypertension are two. One is to, as I said earlier, to identify certain secondary causes and then assess for hypertension-mediated organ damage, which is a very important risk factor in as far as hypertension is concerned. The medical history, so again, remember this, and this is something that I drill into my patients as well. Majority of patients, about 80% of patients with hypertension are asymptomatic, and when patients are told this, they kind of give a surprising look to us, really. So again, it's something that you need to understand as well, that an overwhelming majority of patients who do have high blood pressure don't feel it at all. They are totally asymptomatic. You think that they'll have headaches, giddiness, etc., but majority of the time this is caught through screening mechanisms, so 80% are asymptomatic. If they do have symptoms, suspect that they may be having some secondary cause of hypertension, or they have some complication of hypertension. And of course, a physical examination of the heart and circulation is mandatory. And then investigations, I like to keep it simple. We don't need to do all these fancy things that, a list of tests. So blood tests, just check their kidney function and electrolytes. And I think a reasonable thing to do is to check their lipid profile and fasting sugar, just to make sure that there is no other added risk as far as they are concerned. A urine to check for protein, important as well. And an ECG, again, is done for multiple reasons. One is to check for left ventricular hypertrophy, ischemic heart disease, and sometimes they do get atrial fibrillation. A common test that we do as cardiologists is an echocardiogram, and you can see what we look for here. And basically the main thing that we look for is left ventricular hypertrophy. You can see the images there. This is basically an echocardiogram of a patient who has an enlarged heart, or we call left ventricular hypertrophy, where the whole of the left ventricle is having increased muscle thickness, and that suggests that this patient has had chronic hypertension. And apart from that, imaging wise, apart from the echocardiogram, you can suggest a renal Doppler and a carotid Doppler as well. Again, these are done with the intention of looking for secondary causes as renal artery stenosis, and to look for hypertension induced organ damage. So what is this hypertension-induced organ damage? Essentially, as defined, it's a structural or functional alteration of the arterial vasculature. It's important. And the importance there, if you detect it, is that it helps in the management of patients with hypertension, because if your patient does have hypertension-mediated organ damage, which I'll talk about as to what we look for specifically, that means that this patient definitely needs treatment. And the choice of medication also can be determined by detecting hypertension-mediated organ damage. So again, if you go from head to toe, as far as what we look for, as far as hypertension-mediated organ damage is concerned, so the brain, patients may have TIAs or stroke, so you can look at the carotid intimal thickening, you can do a Doppler or an MRI. The heart, as I said earlier, we look for left ventricular hypertrophy by doing an echo. Kidneys, you can get renal impairment, so the creatinine levels go up and you get proteinuria. The arteries, so if you look at the aorta, you can do a scan again for carotid femoral pulse wave velocities, and the lower extremities, you can look for the ankle brachial pressure index. And again, the eye simple fundoscopy, you can see retinal hemorrhages, microaneurysms, papilledema. So basically, we look at most of these organs to see if there's any end organ damage due to hypertension, and if the patient does have any of these features, that suggests that they are at high risk of developing some complication, and that requires urgent intervention. Risk stratification, I'm not going to harp on it too much, but it's important. Again, we can't remember this offhand. Maybe it's something good to have in our clinics as well, so that we can maybe, if a patient does come to the clinic, to risk stratify them as to what level of risk are they falling into when you detect that they have high blood pressure. So we divide them into low risk, moderate risk, high risk, and very high risk. And the point of doing this is, again, to determine whether they need intervention or not. Do they need treatment, or do they need medications, pharmacological treatment, or do we just give them some lifestyle advice and come back later? So the determining factors here is obviously the blood pressure. You can see what level of blood pressure you have detected, and then do they have any other associated risk factors as well, which are below there. You can see, for example, diabetes, lipid disorders, hyperuricemia, etc., etc. So we try to determine whether these patients fall into which risk category to decide on how we are going to treat them. So then we come to the most important part of the lecture, I feel, and that's about management of these patients. So as I said, we'll talk about pharmacological management also. However, I think before talking about pharmacological management, it's important to talk about non-pharmacological management and that advice that we give to our patients. So healthy lifestyle choices definitely plays a part in preventing and delaying the onset of hypertension. So that's important, and also obviously it prevents or reduces the risk of cardiovascular disease. So we need to be very, very mindful of that. And of course, lifestyle modification is always the first line treatment of any patient with hypertension or any other non-communicable disease as well. So what are the things that we can talk about? So salt reduction, So I think that's something important from a very important thing from a Sri Lankan context, I think, because I feel that our diet in Sri Lanka is high in salt. So I think we need to talk about that in our patients. We need to ask them to reduce their salt intake. There is strong evidence that reducing the salt will have good benefits, and high salt diet has an influence on high blood pressure. What I normally tell my patients is to reduce salt by avoiding foods that have added salt in them. I think a lot of our diet does have foods that have added salt. Unhealthy diet, obviously, particularly foods that have high nitrates, for example, green leafy vegetables and beetroot, again, helps to control high blood pressure. Healthy drinks. So again, a common thing that we get asked is what type of things can we drink and what we cannot drink. So moderate consumption of coffee, it's a common question. I don't know, I'm pretty sure a lot of patients ask you as well whether it's okay to drink coffee when you have high blood pressure. Again, there is no harm in having moderate consumption of coffee, but green tea, black tea is also reasonably all right. Hibiscus tea, pomegranate juice, beetroot juice, etc. have good benefits as well as far as high blood pressure is concerned. Another question that we get asked a lot is alcohol. Controversial question and a controversial answer as well. So again, if you go scientifically, the scientific evidence is that moderate consumption of alcohol is okay for those who have high blood pressure. However, from a practical point of view, and I'm sorry, my time is out. I think I do have a few more minutes. Is that okay? Not to sound biased here, but again, a lot of males come to the clinic with their wives, and a common question they ask is, doctor, is it okay to have a drink or two? And if I were to be scientific and I tell, yes, it's okay to have a moderate amount of alcohol, I get a nice stare from the wife saying, doctor, what are you saying? So I try to save my life by saying, no, it's not, you shouldn't take alcohol. But again, if I were to say from a scientific point of view, moderate consumption of alcohol does not influence hypertension too much. So again, essentially 2 standard drinks for men a day and 1.5 for women, but avoid binge drinking. So that's the scientific advice that you can give them with obviously your own life at your own hands. So it's up to you to decide what you want to say, but if you want to be scientific, that's the advice. You have to ask the patient to reduce their weight. Again, no doubt about it that there will be some benefits in weight reduction. Smoking cessation, there is no compromise here. Smoking has absolutely no place in any part of in cardiovascular disease as well as hypertension. So definitely important to ask them to stop smoking. And the advice that you need to tell them, if you stop smoking today, there will be effects very soon as well. Within a few days, the blood pressure actually does come down. Physical activity important, exercise, moderate intensity, aerobic exercise, very, very important. Reduce stress and induce mindfulness. And unfortunately, given the current context of our country, that's something that our patients will probably have quite a lot, but we need to try and get them to reduce the stress levels as much as possible. As far as pharmacological management is concerned, I think it's important to understand. I'll try, unfortunately, time constraints won't allow me to talk extensively about this, but I'll try to make it as short and sweet as possible. Again, obviously, data suggests that, unfortunately, less than 50% of adults with hypertension receive blood pressure lowering medications, and I think that's something that we need to look into, and that's probably why the data initially that I presented showed that our pressures are not very well controlled. And importantly, a blood pressure difference of 20 to 10 millimeters mercury is associated with a 50% reduction in cardiovascular risk. So that's very, very important and something to drive in to our patients as well. And so our treatment, so again, pharmacological treatment begins early. So after lifestyle advice, if your patient has, again, depending on your patient's blood pressure level, so if it's above 160 and 100 diastolic or 160 systolic, immediate drug treatment is recommended. You can see on the right side there. If it's less than that, between 140 and 159 systolic and 90 and 99 diastolic, again, whether you start treatment pharmacologically or not depends on whether they, what risk category they fall into. If they're high risk, or if they are having cardiovascular disease, CKD, diabetes, or if we have found that they have hypertension-associated organ damage, again, pharmacological treatment is recommended. However, if they fall into a low-risk category and their blood pressure is not too bad, we can start with some lifestyle advice, non-pharmacological treatment, and re-evaluate in about 3 to 6 months to see if they need treatment or not. So that's pretty much our algorithm as far as starting on medications is concerned. And what choices do we have? So again, there are some changes compared to a few years ago. So over the last few years, the drugs that we use and the medications that we start off with have changed. So, you know, a few years ago, maybe 5 years ago, we used to start on a single tablet and see if we can get some control. So you can see now, even a patient who you start on step 1 is a so-called dual low-dose combination. So now that's something new, isn't it? So that basically means that we don't start with a single pill anymore. There are these combination pills. Unfortunately, in this country, we don't have it very often. But again, the recommendation now is a low-dose combination pill. So A and C, there you can see A means an ACE inhibitor or angiotensin receptor blocker. C means calcium channel blocker. So the combination of a dihydropyridine calcium channel blocker, so for example, amlodipine, cilnidipine, nifedipine, etc., and an ACE inhibitor in a lower dose is a step 1. And then we increase, according to the patient's blood pressure, according to our monitoring, we can step up to a full dose combination and triple combination, etc. So combination pills are the way forward. And the reason is that it's a single pill which has multiple, 2 tablets, and compliance will be something that will be better if you have these combination pills. And step 4, in patients who do not have adequate control despite triple combination, we give this term called resistant hypertension. Then the drug of choice is to add spironolactone. And the rationale for using these 2 drug combinations, there's quite a few reasons, but again, better blood pressure control versus monotherapy. And the most important thing is better adherence to drug treatment. You find that patients prefer this combination therapy where the one tablet has two medications in it, and you can get better adherence as compared to taking multiple pills. However, again, you can see on the slide there that this combination pills, either single pill combination or free combination where we give 2 tablets together, have better blood pressure control compared to monotherapy. So I think that's something that that's the reason why these combination tablets have been recommended now as far as hypertension is concerned. I'll skip that slide. So a little word on resistant hypertension. So that means that the patient's blood pressure is persistently elevated, but something that we need to make sure that this is not is so-called pseudo-resistance, where the blood pressure measurement technique is poor, or the so-called white coat effect, and the patient's adherence is poor, and suboptimal choices in antihypertensive therapy. So we need to make sure that our blood pressure medication choice is correct and we have optimized it to the adequate dosages. Last slides, if I do promise. So again, how do you follow up these patients? So again, we don't aim for miracles. We need to have some realistic goals as far as how to follow up these patients and how to get the control. So the target blood pressure reduction is by reducing the blood pressure by 20 systolic or 20 diastolic to a range ideally less than 140/90. But we need to aim for this blood pressure control within 3 months. So I don't expect my patient's blood pressures to reduce over a few days or a few weeks. I do give them some time. And sometimes patients themselves are a little impatient about this. But we need to tell them as well that don't worry, we need to give you a little bit of time for this blood pressure to get better control. So aim for the blood pressure control over a 3-month period, and that's ideal. And according to the patient's age as well, I'm a little bit more flexible here. So if your patients are elderly, above 65 years, 140/90 is our target. Younger patients, I'm a little bit more stringent with their blood pressure targets, so 130/80 if they are less than 65 years. And again, adherence is important, so try to reduce polypharmacy as much as possible. So the single pill combinations are quite significant. Once daily dosing over multiple times a day, again, your patient's lifestyle may not allow them to take multiple times a day. So try to give tablets which have a long duration of action where you can give them a single daily dose. Try to get their pressure monitored at home. Again, it kind of involves them in the process and they feel important as well. So get home blood pressure monitoring as done as possible. And patient education, very, very important. Educate them on lifestyle intervention, the benefits of optimal blood pressure control, because again, one of the things that they will always ask, doctor, do I have to take these tablets? Why is it important to take these tablets? Can I stop them now? That's another common question that they ask us. So we need to drill in as to why taking these medications are important. So these are the final thoughts. Hypertension is the leading cause of death worldwide. We need to be on the ball as far as hypertension is concerned. Early diagnosis is important because patients remain underdiagnosed and undertreated, as we saw in our slides. Appropriate investigations to identify hypertension-associated organ damage. And start early, commence treatment early, and that prevents complications. And patient education, very, very important, especially with adherence to therapy. Thank you very much for your attention, and I do apologize again for running over, but I try to make it as concise as possible.
Thank you, Dr. Chamara. We can give one chance for a question. Can you?
Thank you very much for the excellent presentation. My question is how to measure blood pressure. We know with the pandemic, a lot of ambulatory home monitoring had been happening, and they use mostly electronic devices. It can be the upper cuff as well as wrist one. And the batteries be different, and there are home monitoring systems. What's comment on best? Because we know that doctors also use the mercury, but occupational not recommended at the moment. And comments. Thank you.
Correct. Yeah. Thank you. Yeah, that's a very important question, I feel, and it's a hard question to answer correctly. Also, I don't know that there's a right or wrong answer there. Just to clarify one thing, I know there are multiple ways to measure blood pressure, and this wrist measurement is there. Unfortunately, not the most accurate. I don't recommend that. And even to my patients, I don't recommend the wrist measurement of blood pressure because that relies on the radial pulse, I believe. So not the most accurate way of getting. So the cuff, of course, is better. And whether the difference between mercury versus your electronic, as long as your electronic cuffs are correctly as long as it's correctly done and the measurement is done correctly, I don't see any harm in checking from the electronic cuffs. Mercury will be probably more accurate as long as your ears are working as well. But again, due to the pandemic, we try to avoid contact with patients as much as possible. So electronic cuffs, reasonably accurate, and that's what is done in most countries as well, I feel. So I think that's the best way. The wrist measurement, I wouldn't recommend.
Thank you very much. We have one more session before lunch. May I call upon Dr. Dilni Baranage and Dr. Sankar Randeni Kumara to chair the next session.
Our next speaker, Dr. A. Prabodhana Ranavira, MBBS, MD, MRCOG, Diploma in Benign Gynecological Endoscopy, CTH, Colombo. Dr. Prabodhana Ranavira graduated from the Faculty of Medicine, University of Colombo in 2005 with a second-class upper division at the final MBBS exam with distinctions in clinical medicine, pediatrics, psychological medicine, parasitology, and microbiology. His exemplary performance during the final MBBS exam was awarded with 6 gold medals. He spent 2 years in the United Kingdom, where he completed his postgraduate training. During this time, he became a member of the Royal College of Obstetricians and Gynecology. After returning to Sri Lanka, he was appointed as the acting consultant in obstetrics and gynecology at District General Hospital, Kilinochchi. Dr. Prabodhana Ranavira joined the Faculty of Medicine, University of Colombo in 2016 as a lecturer in obstetrics and gynecology. He received the Shans S. Ratnam Young Gynecologist Award to the Asia and Oceania Federation of Obstetrics and Gynecology in 2013. He is currently involved in being a medical educator for undergraduates and postgraduate trainees in obstetrics and gynecology. He has many publications in index peer-reviewed journals and has authored many book chapters on obstetrics and gynecology. Dr. Ranavira also works as an honorary consultant and obstetrician and gynecologist attached to the De Soysa Maternity Hospital for Women and National Hospital of Sri Lanka. Over to you, Dr. Prabodhana.
So, thank you very much, Dilini, and good afternoon to all of you. And it's good to be back. I think I did few sessions a few years ago also. And now, today, first of all, I'd like to thank the College of General Practitioners for inviting me for the talk here. I'm going to talk about the gynecological cancers and the role of a general practitioner in actually preventing first and also diagnosing early so that the appropriate referrals are done. So now, even in the audience today, now as a general practitioner or anywhere in the world, they play a key role in providing the health care for the public. And as general practitioners, you see a patient more number of times than any of the specialties involved. And there is immense trust that is, put upon you because, I mean, for me now, in the audience, there is Dr. Ranjan, Sri Ranjan. Now, he inspired me to become a doctor, right? So that, like, as the first doctor figure I remember as a child, and the first doctor figure is him. And then there is Dr. Dushanti. Now, when I was in the faculty, I went for the general practitioner appointment with her. And all these people have inspired me because you all don't know the power as a general practitioner that you all hold because you probably treat the families and you know their histories, their children, their a lot of problems, but they are real, the social problems and all that. So that's a huge responsibility also in a way because they trust you, because there are so many patients that I have. Like when we tell something, they go to general practitioner and ask whether the doctor said this and then come back and say, okay, my doctor said it's okay to go ahead with the surgery and all that. So that's something that I really admire and also, it also makes you that you have to be top of the game. And you have to know, like, I have to know only the down part. You have to know the whole body, right? So you have to know everything and everything I don't like. So that it's something that you have to keep your knowledge updated and because things are changing a lot. And as patients, they tend to listen to you more, right? I'm sure that you will have changed somebody's opinion and say, don't go and do that operation, go to this doctor and see what that person says. And that's the trust that, patient put on you. So, so with that introduction, I would like to talk about few cancers which you can actually make a difference in somebody's life. And these are very common cancers which you encounter. Right, so breast carcinoma is the most common cancer in women and the lifetime risk is 1 in 9. So which means that every woman has, or 1 in 9 women has a chance of developing cancer before the age of 70. So what can you do, right? So one of the things that you can do is to encourage the patients to do what we call the self-breast examination, and especially when they are doing, and also as part of your annual checkups, and it's something that you need to do because in guidelines and say to get yourself checked by a practitioner every year, especially in patients who are considered as high risk where they have a family history, either mom or grandmother has breast cancer. And also, you all know that there's a genetic predisposition. So if a patient has a mother who has, let's say endometrial cancer, bowel cancer, ovarian cancer, or even breast cancer, all these cancers, they increase the chance of, cancer of each other. Like if somebody has endometrial cancer in the mother, the daughter may have an increased risk of having breast cancer. So it's important that because you all know, as I told you, the history, and you probably treated the mother also. So it's important that when you see that patient to kind of, tell, have you done your breast examination? have you done like for the last year, and then let's do it, and then kind of encourage, and sometimes even encourage them to go for ultrasound scans or mammography, depending on their risks. Right, and especially when we are starting HRT or contraception, to check whether the woman has any lesions, and if you find the lesions, to refer for a biopsy or ultrasound FNAC or something like that, so that we can detect. And also there is availability of genetic screening now. So you all know about Angelina Jolie, where she was diagnosed with the BRCA1 gene, and she had what we call bilateral prophylactic mastectomy. And a person who depends on the breast for make money, isn't it, as a, this thing. And when she did it, it's called now the Angelina Jolie effect, because a lot of patients have come now with, screening and be more aware of, the breast cancer, and even opting for what we call bilateral prophylactic mastectomy, because by having BRCA1, they have an 87% chance of developing the cancer themselves. So these, like celebrities doing something like that has made people aware. So you can use those, and to make sure that the patients, if they have a family, and we have the testing in Sri Lanka as well. And early it was very expensive. Now it has come down in prices, available at the private sector. So you can if you see a patient has a family history, try and make them go and get themselves screened, so that they know that they have a high risk. And then according to that, they can follow or manage their future lives. So you all know the breast examination technique, so it's available in YouTube and all that, and then encourage patients to do it and give links so that they can go home and check a video and then start doing by themselves. So next we come to, which more relevant to my side, which is cervical cancer, the second commonest cancer in Sri Lanka. And you all, as you all know, HPV or human papillomavirus is the causative factor, right? And it has a very long, what we call a precancerous stage. So, somebody can get HPV infection now and develop cancer after 10 years, right? And one of the commonest presentation is postcoital bleeding in the young age, or even postmenopausal bleeding at an old age. And so you have to really look into them, especially when they come and tell you that there is postcoital bleeding, and it has, you need to, check. And you all know that HPV, now we have vaccines, I'll come to there, and then if you get the vaccine, the majority actually clears by themselves, but some will persist and change the cells in the cervix so that they go on a, what we call, earlier we used to call it CIN1 and up to 3, now it's called squamous intraepithelial lesions, and low grade and high grade, right? And then over a period of 5 to 10 years, they can change into cancer, some eradicated, but some will go on and make cancers. And the sad thing is, by the time they're diagnosed, they are pretty advanced, right? And though there is a proper screening method available where we can detect cancer at a very early stage and cure them 100%. Now, if you look at it, when you say stage by stage, when you have endometrial cancer and cervical cancer, stage 1 of endometrial cancer has a poor prognosis than cervical cancer stage 1. But problem is, endometrial cancer we tend to find at an early stage, whereas cervical cancer we tend to find at a later stage, and therefore the prognosis is poor. But one of the best screening method available for any cancer in the world is cervical cancer. So in other countries, seeing stage 3 disease is a very rare phenomenon, especially in the UK, right? We have an established system. Sadly, our patients are not, utilizing it, especially because of the speculum examination and the pap smear, which may not be culturally that accepted. So there is new ones, what we call the HPV testing. I'll come there. So one of the things that you can do is now from the school programs or vaccination, they are given the cervical cancer vaccine, HPV vaccine. And sometimes even now we get mothers and asking whether it's good to get, because there are myths, like people are saying, like in the COVID vaccine, that they become subfertile or something like that. So you have to tell these are myths, and this is something you can prevent. And usually it's given between 10 to 14 at school. Also, it can be given to anybody who has not been sexually active at any age. That's the important thing. And the idea is when you have your first sexual encounter, whether you're married or unmarried, there is a chance of getting infection. So if you're really sure that you didn't get the infection, even in that instances, you can consider giving the vaccine, which is a bivalent, you're given twice, and which can have so far for 10 years, the protection is there. Still the studies are going on. And also, after, like in UK, they start screening from 25 years of age because they start sexual activity rather early. But now in Sri Lanka also, this trend is changing. I see a lot of patients who are sexually active without marriage. So, like you should not kind of label or kind of, have these now Sri Lankans are like this and it's in not England. And now in the WHO recommendation is 30 years to start in countries like us. But our national guideline is from 35 years, every 5 years until 65 years for cervical screening. But very soon it will change to from 30 years. And you encourage that all MOH officers has the facility to do it. And also, now we are doing a pilot study in MRI for HPV screening just to get a swab and see whether the HPV viral particles are there. If it's there, then they go for proper testing. Though it's pilot study in the government sector, if you refer to the government sector in the private sector, it's not freely available, but anybody can do it. So rather than if somebody doesn't want to do a pap smear, they can go for a smear with HPV, and if it is positive, they can go for colposcopy or further, thing, and anybody can do it. And the other thing is the important for repeated studies. So some people will get this first pap smear and then forget about it for the next 10 years. The idea of doing in England, they do every 3 years until they are 50, and then from there onwards, every 5 years until 65. Because if you miss it once, there's a chance that you can get it in over, because it's a cancer which can take about 10 years to develop. So at any point, you can take it. So in a 10-year time, they get 3 times checks in England, right? So here, at least twice. So for the repeated, so every 5 years, encourage them if you have not done a smear test. And in the UK, it's actually the GPs who run the show, which we call the call and recall. They will call you and say, come, your pap smear is due, and you keep on sending letters until you do it, right? So here, when the patient comes to you for any ailment, ask them, have you done your pap smears? If not, encourage them to do it. And each time, there are certain things that you need to ask, because at the end of the day, the whole, looking after the whole well-being of that patient, the responsibility lies with you because they trust you, they come to you all the time, right? So, and especially in the diagnosis part, if somebody is coming with postcoital bleeding, postmenopausal bleeding, perimenopausal bleeding, there's a vaginal discharge, and if you can do a speculum examination, please do, and see whether there is any abnormality in the cervix. If you are don't want to do it, refer to a gynecologist or even MOH officers to see whether they need further testing, right? And sometimes you get the reports like you have sent, and the patient comes with a report inadequate sample, or what we call low-grade, either CIN1 or low-grade SIL. And sometimes we feel like it's okay, it'll go away, but you have to encourage them to see whether if the symptoms, especially if the symptoms persist, to go for repeats. Usually we repeat them by about 6 months. Next, we are going to talk about ovarian carcinoma, again the third commonest cancer in women, and sadly 70% of ovarian cancers are diagnosed at a later stage or advanced stage, so the prognosis is poor. Because they don't have very specific symptoms. Most of the symptoms that we are treating for gastritis, age, are the common symptoms for ovarian cancer. So in other countries, we call them red flag symptoms. So if somebody is coming with loss of appetite, bloating, abdominal discomfort, you need to kind of, and if they have especially if they have a higher, they fall into higher risk group, like having cancers in the family, or they are in the old age group, because it's common in the old age group, you may have to do a CA-125 or ultrasound scan of the abdomen, and pelvis. And so if you look at the NICE, you will have it. So I'm just kind of put it down, not for you to read it, just to see that it's available in NICE guidelines. So these symptoms we call red flags, especially if they're coming with a repeat consultation. Please do refer them, do what we call CA-125, and then you see whether there's a family history. And if they are high risk, please refer them for a scan plus a consultation by a gynecologist. Then we come to endometrial cancer, right? And this is something I need to kind of give a take-home message for you guys, right? So one thing is it's diagnosed in early stage in more than 90% of the time. So there is a cure, and most of the patient can have 100% cure, or thing. And also what we say is there is no place for population screening, like in cervical cancer. Not every patient should go for screening. And the other good news is like 90% of the patients who have endometrial cancer will present with postmenopausal bleeding. So in other words, if postmenopausal bleeding, if somebody comes with postmenopausal bleeding, there's a 10% chance that is endometrial cancer, and 90% of the time it's at an early stage. So you have, because a lot of time they come to you first. See, there's a discharge or bleeding. And the other risk category is the perimenopausal group, where usually after 45 years, if there is a change in their periods, they have a 1% risk. 99% it's a hormonal, as we all know, but there's a 1% chance that it may be endometrial cancer, or what we call hyperplasia, which is a precursor for endometrial cancer. So what can you do, right? And you take postmenopausal bleeding very, very seriously, right? So don't say it's hormonal, because yes, it's true, 90% of the time it could be atrophic vaginitis, just an infection, it's just age. There is, the skin has become very thin, and that may be, or maybe she is having a prolapse and there's a debicuous ulcer or something. But do examine if you want to, but usually take it very seriously. And if they fall into especially if they are having a high risk category, that is obesity, having high blood pressure, having a family history of cancer, the cancers that I told, and especially if they have done the gene test, they are BRCA, or any of genetic conditions are positive, send them for ultrasound scan and or gynecology review. So what we do is we do ultrasound scan, and then we look at the lining of the womb and we measure the thickness. And now if the thickness is less than 5, we should not do anything in the guidelines. And sometimes when we see a scan, we see what we call focal thickening. That is not the whole endometrium, but there are suspicious areas. Then we have to, the gold standard is to put a camera inside, we call hysteroscopy, and then take a biopsy and come. Now, as you all know, with experience, some of our patients, when they come with a postmenopausal, we are suspicious, like the 5 millimeter is not there. And sadly, especially if you're working in a periphery, the scanner is looking at, from a, crystal ball or something like that, right? You can't see, you have to imagine that there is endometrium and your mission. So we are talking about this 5 millimeter, because 5 millimeter, 6 millimeter, you have to do a biopsy. 5 millimeter, you send the home patient. But that you have to have a very high-end machines, which we are not available in most places in Sri Lanka. So what we tend to do is we do a PIPL biopsy. It's very simple procedure, it's office procedure, and all the hospitals in the government sector has this small gadget, and it takes only a few seconds, and patient have slight pain, you come, you do it, and you send the patient home. We send the sample for histology, and if the diagnosis comes as either hyperplasia or cancer, then we can treat. So though we say that 5 millimeter, sometimes we tend to do a biopsy. And especially when it comes to hysteroscopy or DUA-DNC and things like that, we are a little bit more vigilant about the measurements. But if we can do a simple PIPL biopsy, we tend to do it then and there, so we know that patient is safe, and even though she doesn't come for a follow-up. And the criteria would be if they come, we do measure and it falls less than 5 millimeter, but if they come with a repeated complaint, then we have to go for biopsy regardless of the size. And also, especially when they come with what we call after 45 years. Now, this is where I need to tell you all, because the cancers are becoming slightly commoner. It may be in the environment, we don't know, maybe genetic, we don't know. Especially after 45 years, because I have seen many will give notisteron or tranexamic acid, then let's say it's okay, it's hormonal and all that. By the time they come to us, it may be a little too late. So like if they are more than 45 years, especially if they fall again into the high risk category, cancer history, hypertension, diabetes, obesity, all, and patient with polycystic ovarian syndrome, late to have babies, less number of babies, late menopause, or like still at 50 they are still bleeding. These patients are high risk for endometrial cancer or hyperplasia, so they may need referral. Don't treat them, and you have to look into all this aspect before prescribing, especially hormones, right? And it's important because you guys play a key role, and because most of the patients that has come to me are referred by you guys. So you all are doing a good job, because like they go to you first before coming to us. So you are the one who will make that diagnosis or suspicion and then send to us. It's important, because sometimes I also feel they have gone to several and they have been treated for then, and we come up with a diagnosis of endometrial cancer. Right, now vulval cancer is rare, right? And then there's when I told a colleague of mine, or a cancer surgeon, that I'm going to give this talk, like I was not actually going to incorporate this to my slide also, because it's a rare cancer, right? And it's very rare to see, and it's a very high-fi. We also don't treat, we usually send for a gyne onco surgeon. And when I just want to get the currents, any evidence or new things which has come up. So he told me to tell you guys, as because it's the general practitioners, the referrals for this is very, very minimal. And by the time they come, it's a bit too late, right? So when a woman comes, so this is his take-home message, he told me to tell you all that if somebody comes in old, because it's a postmenopausal age usually in the majority of the patient, and when they come with itching, please look at their vulva and don't attribute to candidiasis or any infection. And you can, in about more than 90% of the time, you can see a what we call the leukoplakias, a small white patch in the vulva. If you see it, please refer them to onco. Not for us, even not a generalist, send for a oncogyne person, because it's a very specialized thing, and we have to take a biopsy. Nowadays, we don't do radical, surgeries, because early days they used to do something called the butterfly incision, where they cut the whole groin and make it. But now they do small, operations, and then if needed, only the lymph nodes in a very, what we call, either in 3 stages they will operate, depending on what they find in their histologies. So the commonest symptom is persistent vulval itching and soreness, and especially if they are taking that it's burning and all that, you need to really check and then send for that. Is sadly, as you all know, it's a common symptom as well. So having vulval cancer is a rare thing. However, according to them, the referrals from the normal doctors to them are very rare and are minimal, and then by the time they find, it's usually ulcer and it has spread a lot. So this is when somebody's having this lichen sclerosis and all that, you need to, like if the patient say that I have been diagnosed with lichen sclerosis or something like that, you have to be more vigilant, and they are the patients who have a higher risk of developing vulval cancer. So just to kind of recap of what I want to kind of convey today, right? And because most of these gynecological cancers are common in the older age group, and we are in aging population. So you will see more and more patients with cancers, especially gynecological. So you have to be aware of them, and also you will see them first. They will come to you, and it's your responsibility to kind of recognize them and suspect them, and then send them for appropriate referrals. And also you play a key role in prevention, as I told you, especially when it comes to cervical cancer, by vaccinations and vaccinations and cervical screening. And also one more thing that we see a lot of PCOS patients and patients who are nulliparous, you know, like a lot of people are now don't want kids and they want to live their lives, and some people don't want to marry. Now, these are all personal choices. We have to go by them. But like I usually tell nuns also, take OCP for 1 year, because it has shown to reduce the chance of endometrial cancer, ovarian cancer, bowel cancer in a significant way. So continuously for like normal 21-day cycles for 1 year. So I usually, when it comes to, but only thing you have to kind of see whether there are any contraindication, like if they have any medical disorders, you have to be really thinking of it. And if they have, migraine and hypertension and things, you can't, right? DVT, breast cancer, you have to think twice and all that. So there are a lot of contraindication, but if the contraindication not there, encourage them any point of their life. If they take OCP for a year, combined contraceptive pill for a year, they reduce the risk compared to somebody who have never taken it. So it's important. And always think beyond the system. If somebody comes, whether it's a cancer, and identify the high-risk patients, encourage them for screening programs, and encourage them to add in. And one more thing now, a lot of patients, just give me 1 minute more, that is that patients, when they have cancer, they are scared to go to Apeksha or, for cancer treatment, because they think, like, I'm not going to die. Because nowadays, there are a lot of treatment for cancer, and outcomes are usually better. So, and also sometimes they will have a lot of symptoms when they go for chemotherapy, radiotherapy, and they try to give up. And sometimes they come to you for symptoms, and encourage them to go through the symptoms, encourage their, whoever looking after them to make sure that they go for appointments and do it, because, we have a lot of loss to follow up in these patients, and seen by you guys. And it's important, if you again ask them how they are doing, you can give some medicines, ondansetron and things for vomiting, and make their lives a little better when they are undergoing chemotherapy, radiotherapy, sometimes which may not happen from the hospital. So thank you once again for inviting me, and if there's any questions, I can answer.
Probably we can entertain 1 or 2 questions, not more than that.
Can I speak?
Yeah.
It was a very informative lecture. Congratulations. And we learned a lot. This is a question, a patient who is on tamoxifen. Do you have to screen them very often for uterine polyps or uterine abnormalities?
So what they say is, if they are coming now, for instance, now here where we disregard the endometrial thickness, if somebody is on tamoxifen for cancer or whatever, if they come with postmenopausal bleeding, they need a biopsy. There's like no scanning, even if they scanning, because they will have these changes which might not detected, and even if it is less than 5 millimeters, we usually go ahead with at least a PIPL biopsy.
If the biopsy has been done, and if there is some recurrence, what would you do?
Then we send to the oncologist and the oncologist, because usually then we will take it out, usually, because now even if a precursor, like what we call hyperplasia with atypia, now we don't go with simple hyperplasia, complex hyperplasia, we go with hyperplasia with atypia or without atypia. So without atypia, we can wait a little, we can give a little bit of progestogen and see whether, and we have to always do another, after 6 months, another biopsy and see whether it has reverted back to normal. If not, anybody with having hyperplasia with atypia, or despite treatment, it continues to be, without atypia for a long time, in the Sri Lankan context, we tend to do a hysterectomy. And then, because especially when there is atypia, there is a 50% chance that there is a concurrent cancer at early stage as well. So we are a little bit more vigilant on there, unless they have not made a family, and then there are different treatment options are there, but usually we send for, that kind of patient to an oncology center, for they will discuss about the options and come up with the best plan for that patient.
Once the hysterectomy is done, would you still continue the tamoxifen?
Yeah, then it's fine, because it's for the uterus is the problematic, because they need it for the cancer part from the breast. So it's a drug which has shown to have a lot of what we call reduce the recurrence and all that. Yes, when the uterus is not there, we don't need to worry about it.
Vaccination of the younger girls?
The newer data says it's good now, because now, like the COVID, like earlier people were not doing it, now they did it, and now again little bit, now they are reluctant to get it because now it's kind of okay. But same happened with vaccine. When it started, there were a lot of issues. A lot of mothers came to see, to meet us, and I think probably, most of you all have seen mothers are come bringing their children, asking whether it's good to get it. But now, because it's in the EPI program, people are okay with it.
Even in the private sector?
Private sector, because now it's the EPI program less, but still, yes, they come and ask us whether it's okay, and especially if we take a history and if they're not sexually active or never been sexually active, we tend to get them vaccinated.
Thank you.
No other questions?
Oh, yes. Not really. That is, we do it only when there had been a cervical lesion. If there's a cervical, like especially if there's, let's say, even cervical cancer at the early stage, they have a follow-up. So we do 3 monthly pap smear, or wall smears we call them, for 2 years, and then 6 monthly for 2 years, and then yearly until for a long time, about 5 years. If there's no recurrence, only we stop it.
So if they've had a hysterectomy for a non-malignant thing, then
No
you don't
need.
need pap
No
smears.
need.
Okay.
Right, thank you very much. Thank you, Dr. Prabodhana Ranavira, for that informative and also very focused lecture. Now Dilini will present a token of appreciation to Dr. Prabodhana. As we are running behind the time, we are quickly moving to the next session. It's a pleasure to have Dr. Samanmali P. Sumanasena, MD, FRC PCH, who's a professor in pediatric disability in Department of Disability Studies in the Faculty of Medicine, University of Kelaniya, with us. She's also an honorary consultant pediatrician in Ayati National Center for Children with Disabilities and North Colombo Teaching Hospital, Ragama. Professor Samanmali has pioneered in establishing state-of-the-art multidisciplinary child development and disability services in Sri Lanka for children at risk and with neurodevelopmental disorders. She is a postgraduate clinical trainer for the PGIM in multiple pediatric and child neurodisability specialties and MBBS and multiple allied health undergraduate courses. Dr. Sumanasena has contributed to multiple national level child developmental and disability service establishment, training and guideline development with the collaboration with Ministries of Health, Education and Social Services. She is also the principal investigator of the Cerebral Palsy Register project for Sri Lanka and has contributed to multiple international collaborative research projects, including the HELIX trial. And she has numerous publications in peer-reviewed international and national journals. Over to you, madam, to talk about Is My Child Delayed in Development?
Good afternoon, and thank you so much, Sanka, for that very lengthy introduction, which I wrote myself. And thank you so much for inviting me for this conference, because I really value the fact that this college has identified child development as an important item in today's agenda. A big thank you to Dr. Dilini Bararanage, who is my colleague and my friend, and to the entire committee and the Council of College of Pediatricians, also for identifying this time slot. I know that you all are hungry, but I hope I'll be able to keep you all awake during the next 20 minutes. So it's a very broad topic, and for me, it is quite extensive as well. So far, many of you all, you may think that child development is just a very simple topic. That is how our pediatricians think, but it is not. It is a very extensive and highly evolving topic with a lot of new advancements. So I don't know, for me, I learn every day and I receive so many new articles coming up in this field. So you have to keep in touch with this topic, and I will recommend you all some very good websites to refer and to continuously work with, right? So during the next 20 minutes or so, I will take you all through these key points. I will not talk a lot about science, but I will try to focus more on deviations in development so that you will understand at least to pick these kids. Now, I won't talk much about management because I think if you all pick them up, that will be good enough. As I said, because it's very extensive, I don't think we can talk about management within 20 minutes. So today's main objective is for you all to identify these children and talk to the families. So what is child development? It is a process that results in achieving new skills from birth to school age. So basically, after entering schools, there's rarely any development that takes place. So the foundation is laid in the early years. So that is a very important key message that you need to take home with you. How many of you all see children in your practice? Can I see a hand count? Okay, thank you. So I hope this will be a useful lecture for you all. So child development is measured according to skills achieved. So majority of you might remember child development from school days, right? Many of you all may not have updated yourselves about from faculty days. So for us, it was a boring subject because we had to memorize so many milestones, right? Sankar, you agree? Yes. It was such a boring subject. And for me today, if you ask me, give me a milestone and ask what age is this, I don't, even though I call myself a professor in pediatric development and disability, I don't think I will remember all those because it's not important that you remember everything and you memorize things because there are valid charts that you can always refer. You don't need to memorize these things, but you need to understand the process. Then you can work it out. So that is my message to you all. So there are four main domains, but within these domains, we might combine one or two together. So the most important and the most significant domain in child development is cognition. But unfortunately, that is the area that majority of people don't take any notice till children go to school. All of you here are doctors because you all had a good cognitive development, right? But imagine if we were not walking, we would be more worried about it even though we are doctors, right? But we have to appreciate the fact that we have had the ability to learn and become doctors, though we may not be able to walk. But physical skills, motor skills are considered more significant by the majority. So cognition in children are assessed through play, primarily, how kids play. Then social, emotional, and activities of daily living. These are so important. The majority of problems that we see in society are there today because we have, as parents, the populations have totally ignored the social, emotional development of children. Because if you may, majority of you look very young to me. You may be having small children at home. If you are mature, you may be having grandchildren at home. If you think very carefully, the area that we rarely give any notice is to the emotional development of children, right? So this is a very, very important milestone as well. Then we have the language and communication, how we talk, how we express ourselves. And then finally, we talk about gross motor and fine motor skills, right? So in a developmental clinic, we assess the first three, the cognition, language, and motor, by ourselves. We can do it by carrying out certain activities, but the parent reporting and observation is more important for social, emotional, and adaptive skills. Adaptive skills are mainly about how we manage our activities of daily living and how we manage situations. So a milestone can be as simple as smiling responsibly, or it could maybe as complex as talking in sentences using words. And one milestone that a child develops may be dependent on the previous one that they have achieved. So achieving milestones is like a stairway. So you build one on the other, and milestones have defined developmental age ranges that they should be achieving it. So for example, if we take this, I have drawn the arrow. Can I use this laser pointer? Yeah. So if you look at this milestone, running, it is achieved from like 25% of children will achieve at like 12 plus months, and nearly 100% will complete achieving it by 18 plus months, right? So, but if you take this light blue shadow, shaded area, that is the period that majority of children will achieve that skill. So developmental age ranges are given based on this, and evidence shows that in different communities, children may have slight variations, though generally in a population, they achieve this in a standard age range. However, remember, if you take skills like adaptive skills, activities of daily living, eating by self, are very different in different parts of the world because of the social and the cultural influence on these skills. So this is what I said, that a child will build one skill on the other. So if you put a child, baby, prone, they will achieve to mobilize in the prone position, to kneel on the prone position, and then finally to sit down and reach for something, right? So that is a milestone achievement according to the ages, but also following a sequence of events. So what is normal? They develop these within a different age range. However, we define the normal age ranges based on the populations, and those are available in the charts. You don't need to memorize those. Please remember, don't memorize those. But medical students, we ask them to memorize. But practitioners don't need to memorize, right? And at different age points, they will achieve this, but within the range. The most important thing is we should be aware. We should be aware about these milestones, and the best way to do that is by referring charts. Now, a little bit about neuroscience about child development. Neuroplasticity is the process that it takes place. Neuroplasticity means that there is a best critical window period that the brain development takes place best, and that is from 0 to 3 years. So that is the most important age range, right? So tracking a baby's development therefore is very important to see how the brain growth takes place during the 0 to 3 age range. So if you look at the brain weight, which signifies the structural growth of the brain, you can see by 3 years they have achieved almost the adult weight. Similarly, if you look at the synapse patterns, how the neurons arrange themselves within the brain, the complexity of the synapses will increase with age, and by nearly 2 years, they have a similar synapse pattern to adults, right? So that is the neurosciences. So again, this shows how from 0 to 3, children will develop the best synapse formation from 0 to 3 years. This is also, it is also important that we detect these children if they have any delays or if any concerns. The entire message about this chart is to let you all know, don't wait to detect a developmental delay. Best happens by 3 years, and whatever you do after that is not going to be helpful for children. So if a parent is concerned at 6 months, don't tell them, let's wait and see. That is the message here. And that is because every second, a child's brain has the ability to form about 400 synapses through learning by experience, right? So this is a key message that I need to tell you all. And if you look at the brain size and the neuron count of several types of other mammals, you can see that there are brains which are heavier, but if you look at the neurons, we have the most as humans. So humans by evolution are made to have more neurons because we can use it. So please invest on our neurons, on our infants' neurons, because then we can help them to achieve better. So in the neuroplasticity also you learn how children learn skills. All children are like, we are like computers, our brains. They are by evolution programmed to learn certain skills. That is achieving milestones. So children, so for example, every baby will smile. That will naturally happen. You don't need to teach them to smile. Now, how did we learn to walk? Did anybody teach us to walk? Did anybody teach us to talk? No. We just learn it naturally, right? So that is called experience expectant. They are expected to do certain things. But now when the baby is smiling, the parents will go and talk to them, right? So what if a baby does not smile? So there will be a problem. That is the delay that you will be concerned about. So if a baby does not smile, nobody will smile with them. So then will the neural synapses form? No, right? So similarly, when a baby is crawling, somebody calls them to get up and come to them. So babies need, they are programmed to develop, but they need stimulation, adult interaction, activity, time for them to develop into the human being that we expect them to be. So that is about neuroplasticity. Two things will decide that: your genetic composition, how well you are composed to develop into a successful human being, plus the nurturing. So nurturing means not only good health, it is about good health, nutrition, safety, and the opportunities to learn through stimulation and being responsive caregivers. So if a baby is not smiling, parents need to come and tell the doctor the child is not smiling. That is responsive caregiving. So that there will be some action taken. So parents are always right. Please remember, parents are never wrong if they are concerned about their child's development. Problem is parents are not aware. That is the problem. But if they are aware, they are right. and majority of families identify motor and physical concerns and not the others. So how do we track the development of children? So they might come and tell you they are not walking, they are not talking, they are not learning. Is this adequate if we address these needs? How many say yes? Is it adequate if we give attention to them saying, my child is not walking, not talking, not learning? Are we happy about it? Actually, I will not be happy about it. Why I am here today is to request you all not to be happy about it. Right? I would really appreciate if all of you all adopt developmental screening and developmental monitoring into your practice. That is my role of being here and accepting this invitation. So learn the science and act early. That is what we need to do. We need to learn the science, we need to act early, right? As parents as well as healthcare workers. So there are things called developmental monitoring tools. Our CHDR is one of those, but it is not a great tool. So I need to come out of this. No. Sorry about it. Yeah. So these are the, I would recommend you all to use one in the left-hand side, right-hand side of yours. So that is, those are the CDC website charts. If you all can download this, you all can print those. There's also digital tracker, right? So use this in your practice, and there are some beautiful videos how general practitioners in the US use this in their practice, and they have had super outcomes. I'm ready to help you all as being in the referral pathway, but it's important that we use this in our practice. There are specified screeners like the MCHAT, etc., which I'm not going to talk about. And you can do developmental assessments in your clinics, you can do regular follow-ups and surveillance, but those are not essential. Those will take time, and those are not essential. If anybody is interested, you can learn more about it, but if you can do the monitoring properly, that will serve the purpose. And if you look at the patterns, now this is important to understand, majority of children will follow the normal, some will stop. That means there's going to be a regression, right? Following acute illnesses like Guillain-Barré syndrome or a meningitis, they might stop, but then they might recover. But if children are growing slowly, achieving developmental milestones slowly, still you need to take action, because you can't sit and wait, because there is a time period that the brain will learn. After that, the brain won't learn. So don't tell parents of children with Down syndrome, these are slow developers, don't worry, they will develop someday, right? Because they'll never develop. Be proactive and get the parents to stimulate children and get them to learn. So early intervention is the key, and it has to happen from birth, and that will make the children go through this zone of modifiability. And so the lower line shows the trajectory if we don't do anything. The upper line is the normal. And something between, you would be able to bring them and make them more functional and more productive to the society. All evidence show that if we help children to learn, so this is experience dependent. So a baby who can't crawl, we support them. So these are the intervention methods. We support them to walk so that they learn. I'm not going to talk about intervention. I told you I'm not talking about intervention today. These are things that we can do. So we have to identify the at-risk kids. We could identify them by 6 months, 12 months, or even at 18 months. We have to use the evidence-based methods, and we can identify the at-risk ones, the ones with stormy neonatal periods. Please take over them and check them regularly. children with dysmorphic syndromes, children who do not look or respond to sounds, whether there's a hearing impairment or a visual impairment, the seizure disorders. At least these 5 groups, if you follow up, and most importantly, the siblings of children with developmental disorders, if you follow up these 5 groups, we will cover a lot. And add to that any family who is concerned. So this is the tracker which I was talking about. And just to run through a few conditions, I will talk mainly about cerebral palsy and autism. I thought I will touch more on autism because it's commoner and it is what you all are more seeing day by day. So any child with a motor concern, do the basic neurology. You know all this. I don't need to talk about this. And there is something called the general movement assessments that we can do. It's looking at the baby's movements, and we can do it in babies, newborn babies, at any time of POA and till they're 5 years and 5 months. And remember, now we can identify cerebral palsy and diagnose cerebral palsy with confidence at 5 months. Right? We don't need to wait till they walk. So we can confirm the diagnosis with a 98% reliability by just looking at their movements, right? So there are these. Okay. Please don't video this because these are my kids and they haven't given permission to video. So by looking at these movements, we can say now this kid is perfectly normal today. This is a very old video, right? But if you look at this child, you can see how tight this baby is. And if we did not intervene at that point, this child would be in a wheelchair, right? So this change we can do with our brains, with their brains, if we do the interventions. So if we miss this, remember, if they cannot sit independently by 9 months, if they cannot bear weight on their feet by 9 months, and if there's an asymmetry in the use of hands, there's a hand preference by 9 months, you can still suspect cerebral palsy and do the intervention. So if you miss the GMs by 5 months, by 9 months you can close the case, right? So let's go to autism. It's a long topic. And I love autism. I can talk so much about it. It's like 1 in 44 in the US now. I think it's at least 1 in 60 in Sri Lanka, but we are not having any figures. The most important thing to remember is if by 4 years we don't diagnose autism, they all end up with cognitive impairment, intellectual impairment. And we are losing a large population of children who have the potential to have a better IQ because we have not diagnosed them, right? It's common in boys, but it's more tough in girls. Girls with autism respond to interventions very, very poorly. So I'm not going to run through definitions because that is theory. Remember, we can, I might take another 3-4 minutes extra. Remember, we can pick them up as early as 6 months. We diagnose autism as early as 6 months. But by 9 months, we can confidently say this child is at risk for autism. We can't diagnose because there are no international guidelines yet to diagnose before 18 months. But we are working towards making it at least 12 months because we can diagnose autism early. Early phase regard and responsive social smiling is the most important thing. You might have seen these videos. I would have shown this recently at the GP's workshop. Now, if you look at this Baba, she's beautifully looking, smiling and interacting with a therapist who is wearing a mask and a face shield. Right? I'll show you another video. This is a little girl who is a sibling of a child with autism. You can see how blank her face is. Just staring and looking at the environment more than the person who is talking to her. Look at this smile. right? All over, right? So autism is a neurological disorder. It's all to do with smiling mechanism, vision, etc. And whereas this one is looking at the mum, this is the mum, and you can see the responses are so minimal, right? Not that she doesn't want to respond, not that she doesn't want to respond, right? All children love to respond. As humans, we love to interact with others, right? So this is another excellent website. Please go to Autism Navigator. You will learn everything about autism. Everything I'm talking about autism is from Autism Navigator, the most wonderful website on autism. Lot of videos comparing normal and abnormal in babies, right? And Baby Navigator is another wonderful website. So again, you can confirm 9 months. At 9 months, if they do not speak by 18 months, you can confirm. Does not speak by 18 months, lost any whatever the language they had by 18 months, or abnormal speech and behavior. Somebody was asking about hyperactivity. Majority of us misdiagnose autism for hyperactivity. They are not hyperactive, they don't know to give attention. So they don't connect with human beings, they just walk around looking for objects, right? So these are the key messages. Babies are natural explorers. Babies are drawn to look at people and interact. We are naturally interacting. That is being human. If we don't interact, we are being inhuman, right? So that is the key about autism. So a hyperactive child will come and talk to the mom, tell something to her, and then still run around, right? Child with autism will just run around in the room. They will not respond, they will not interact. That is the difference. And we don't label kids as hyperactive till they are 5 years old. And we don't treat. Because children spend about till 3 years, you can't get them to jointly interact over a long time. So then we can't label them hyperactive. So these are from the Autism Navigator website. I'm not going to go through this. I just took some screenshots to show you all. These are the material that you can print and you can keep it in your clinic or you can put it on the walls and ask parents to let you know if there's anything that is concerning them, right? So now if you look at the first two, the child is looking at the mother. The next two, the child is not looking at the caregivers, right? They don't share enjoyment. Sometimes they might smile, but they are not sharing the enjoyment, right? So these are very subtle signs. You must train yourself to observe. So you don't need to train yourself. You use these leaflets. That's it, right? So there are 16 signs. I'm not going to run through the 16 signs, but I'm just going to show you all these are there in this website, pictures plus videos. So please go through. Just to tell you all, excessive interest in objects rather than humans, right? So they'll be looking at things and parents will come and say, my child can build towers, they know all the numbers, they know all the letters, but that is sadly autism, right? So please remember, autism is a very important condition that you need to know about. And I told you all at the beginning that I won't be able to cover this topic within 20 minutes or 30 minutes. But I think your job is to catch them early, monitor the interventions that we would recommend, and help with the rest of the management, nutrition, etc. And make sure they don't get abused at home. Then, sorry, I'm going the other way. So remember, in Colombo, Kandy and Gampaha, now we have dedicated, established child development and disability services in the government sector. So you can always refer to them. Kandy at Digana, Colombo at the Maligawatta Hospital, and at Gampaha at the Ayati Center. and also the Vattupitivala Hospital. We have a dedicated community pediatrician in Gampaha district who is specialized in neurodisability. She will become a consultant very soon. Ministry of Health is developing guidelines. We will share it with you all soon. It's in print now. So that is all I have to tell you. Please take home these messages. Improve child development literacy amongst yourselves and your patients. Appreciate child development as the key feature to success in life. Screening and monitoring, and refer without waiting. I'm sorry I took nearly 10 minutes extra. Sorry.
Any questions?
What is the age to put a small child into a daycare center?
Madam, it's a tough question. I know people who send children to daycare even at 4 months. In the US, they have these really nice caregiver centers. I think rather than pushing families not to work, especially during this kind of economic situation, it will be more important that we make the caregivers at these daycare centers aware how to handle these children, give them opportunities to learn. Actually, in the US, they have found in poorer populations, children who go to daycare centers do better than at home. So I think we should invest on any opportunity we get. So we should train the daycare center workers to be more responsive, and I think that is the way forward.
Madam, one more question. Now, suppose we detect a child in our practice through various charts and what you have just shown. What is the practical way to refer? Like we go through the MO, OPD of those particular hospitals that you mentioned, or we can directly refer to the community pediatrician? Or what's the pathway for referral, for intervention?
You can directly refer. I just need to make a statement. Now, when I say these charts, they are not confirmative of a diagnosis. They may not be even confirmative of a delay. It is a concern, right? So you have to tell the parents, I have a concern and I'll be referring you. This is not to downgrade anything done by anybody, but the stark truth is majority of health workers do not know about child development that much, and the experience is when we send them to the OPD, they have been turned back saying, don't worry, there's nothing wrong with your child. So you are now specially trained because you attended this workshop, this lecture. So therefore, you have to be a little bit careful. If you are sending to Ayati, where I work at Gampaha district, you just send them to Ayati. Ayati is not in the hospital, it's away from the hospital. We would just see any patient or any family walking in with a referral or without a referral. Vattupitivala Hospital also, if you send to community pediatrician, they will say. Maligavat also, they will see. Our dedicated services, we will definitely see. I can't talk on behalf of the other hospitals, so I'm sorry about it.
Thank you.
Most important thing is making your parents aware, making your families aware. Tell them to come and talk to you if there's a problem.
Yeah, I think it's time to conclude the session. Thank you very much, Madam, for that very informative presentation. I think it's very useful for our GPs. Now I would like to invite Dr. Sankar to award a token of appreciation to Professor Samanwali.
Thank you very much. We break for lunch now.